Good afternoon, everybody. Welcome to this afternoon's talk. Our speaker this afternoon is Karen Denton, who needs no introduction, but I will tell you a little bit. And that is that 30 odd years ago, Karen's daughter, who was 18 months old, was diagnosed with diabetes.
She's 38 now.
She's 38. Type 1 diabetes, and that set Karen on the road to becoming a diabetes educator and working all over the world in diabetes education. Karen then worked overseas for a while, about 8 years, and then came back to South Africa, and it took a lot of convincing to get her to come back to the medical world. But we've managed that, and we're actually getting Karen to be more involved with diabetes again, but that's another discussion for another day. But this afternoon's talk is on why don't my meds work for me? And it's quite an interesting topic. Often people discuss different meds and what are you on and what am I on, and that it isn't working for me, or I tried it, it didn't work. But there appears that there's a whole lot more to that. And so, Karen, if you'll enlighten us about that, over to you.
Thank you. Just give me a moment to start my share screen. Is it showing?
Okay.
Okay. Thank you so much, Belinda. And thank you for the introduction, as always. And I'm also delighted, before we carry on, that Claudette is also with us. And because I'm stepping into a realm that I'm not really a fundi on, I'm very delighted that Claudette is here. So if you have any questions, they will be handled by Claudette, who is our head of science and knows more about genes than the genes know about themselves. So I'm very proud to have been part of the Low Vision Center of Learning from the outset, where we work as a very close and well-functioning team, and we complement each other. And also, I'm equally lucky to be involved in Retina South Africa, where also I work with a team where we also work very closely together, also complement each other in all ways. At Retina, I work in education and advocacy. I have to, by way of full disclosure, let you know that this program is made possible thanks to an unconditional grant from Bayer, South Africa. What we're talking about today is pharmacogenomics. Now, that's a very smart-sounding word, and to some people it sounds quite intimidating. But what does that very impressive sounding word mean? It simply means it is the science of personalizing your drug treatments, your medications, your treatments based on your own individual DNA profile. So no longer is it just a haphazard, let's see if this will work for you, and if it does, it does. If it doesn't, we'll try something different. The approach is developing towards using your own individual DNA profile to prescribe. So dosages, medicines, everything like that will be selected based, everything will be based on you as an individual and not on the average person out there. None of us are average. This is a fairly new science, but when I looked into the literature, I saw that there are a lot of journals, but not only journals, a lot of public magazines, newspapers, and other publications that have been carrying stories around this type of treatment for quite a number of years, using DNA to decide what and how and to what extent you can and will be treated and how you will respond. And in the future, our prescriptions will contain the patient's name, the patient's address, and your DNA profile as well, not only just the script that we get today. Now, when we look at us, basically, humankind is humankind. We all have two eyes, a nose, a mouth, blah, blah, blah. And yes, if we look at people, they might look superficially very similar. And if we look at these two people, you can see at a glance that they're not going to have the same genetic makeup as these people. But the individual variation between the two people standing there, just like the individual variation between the individual standing here, is staggeringly impactful. So we all share a staggering 99.97% of our DNA is the same. So my DNA, your DNA, all of us here today, listening, chatting together, share 99.97% of our DNA. So then, it sounds as though we should really be quite similar, but with only 0.03% makes the differences, like you can see in the pictures here above and below. And that 0.03% determines everything about you. It determines your hair color, the texture, the waviness, everything about that. Your skin color, your texture, your eye color, your size, whether you're short or tall, or your shape, whether you round or apple-shaped or pear-shaped, the kind of physiology that you have that is specific to you, and so much more. In other words, that 0.03% determines everything that makes you uniquely you and uniquely different from any other person. So the genes, as we said, can determine your shape, your size, your height, everything about you. But then if we are so similar, if we share so much together, why then do some people eat anything, and they remain trim? Whereas I will eat one donut and gain a kilo. Some people can have one tot and they're drunk, and others can have 2-3 bottles and they're fine. Some people never exercise but remain fit, while others exercise religiously. They're really good about it, but they never seem to be quite there. And then some people sit in the sun and develop a lovely tan. Others get severe burns after just 10-20 minutes. And we can carry on and on and on with this. Some people can have espresso at bedtime and sleep well. Others can have it at noon and not sleep that night, etc., etc. So if we have such an enormous reaction to absolutely everything in our lives, the exercise, the food we eat, everything, it makes sense then that medicines will also affect people very, very differently. And that is why medicines that work for others might not work for you, and those that work for you might not work for others. And this is why your doctor very often says to you, don't take someone else's medication. That is not what is going to work for you. And I know that some people even say, but I was put onto this product. Why didn't your doctor use this product? Etc., etc. It is individual, even today. Now, we know that variability is part of life. And even if we look at exactly the same disease with the same medication, people will have different reactions or a combination of these reactions. For some people, they will have toxicity, they'll have an adverse reaction, and they'll have no benefit from the medication whatsoever. Other people will have a full benefit with no side effects, no adverse events. They're absolutely fine, and the medicine works fine for them. And yet others will have no toxicity, but the meds just don't work for them.
And then, last but not least, unfortunately, with some medical products, an individual may react well and benefit from the therapeutic side that works well for them. But that individual develops an adverse reaction, side effects, and then continuing that product could be hazardous for their health.
So we all react differently. And the reason, as we have said, it is all in the genes. And it is in that 0.03% of yours. Because just the way our bodies handle coffee, alcohol, food, exercise, everything that we said just now, we will all metabolize our medications completely individually, completely differently. So even aspirins, paracetamol, antibiotics, cholesterol-lowering agents, vitamins, even diabetes medication react differently with different people. And many of you know that I was in diabetes for many, many years. And I found that there are two major manufacturers of insulin worldwide. And I learned very early on that some people responded to the one and some people responded to the other, although they were meant to be identical human insulins. So we are just that different. Everything affects every one of us completely differently, and no exception with medications. Our individual responses are just too different. Now, interestingly enough, DNA-based life is catching on worldwide. And in fact, in countries such as the UK and USA, there's stores that you can go into and you get a band, like the one in the picture at the bottom there. If you can see, it's a little band that you strap onto your arm. And then when you shop, you go according to foodstuffs based on your individual DNA. So you hold up whatever you want to buy, and the barcode will be picked up by the band. It will compare that with your individual DNA that you can have tested at the entrance to the store, by the way. And the results are relayed to the band, from the band, the results are relayed from the band to your smartphone. And you can then shop exactly according to what will agree best with you, what will cause problems in your life, what will metabolize well in your life, etc. This is the way shopping is going to be in the future. Now, it makes sense that obviously the medical profession needs to prescribe medication based on our individual DNA profiles. And a few, very few, already do so. And prescriptions will come not only with your medication, but your DNA compatibility on it as well. The future is approaching. In fact, it's approaching incredibly fast. And pharmacogenomics is a critical area for improving drug therapy and prescriptions in the future. But as I said, it's actually starting in certain areas already. And this relatively new science challenges the widely held view amongst many medical professionals, doctors, pharmacists, and other experts, that drugs have pretty much the same effect on everyone. We know they don't. Now, more than 50 million DNA variations have already been identified, and thousands have been associated with very specific diseases. And Claudette can tell you a lot more about this than I can. And thousands of others are associated with specific drugs, very specific. And there are an increasing number of drugs with labels that include pharmacogenomic information. And based on the associations found between genes and the sensitivity to a certain drug, your pharmacogenomic info will be contained and your prescription will be personalized to you. Interesting, studies already show that medications are ineffective. They just don't work for about 40% of patients with asthma, depression, and diabetes. And I've only chosen those three here, although there was a whole list of others as well. I want to stress here that it is nothing to do with the quality of the drug. So if a drug doesn't work for you, if a medication that you've been given doesn't work, it's not the quality of the drug that doesn't work, it's your reaction. And similarly, it is not a lousy doctor. I hear time and again, I went to Dr. So-and-so and he put me on such and such and didn't work. He's a lousy doctor. That's not the case. That medication simply didn't work for you, because at the moment, all the doctor can do is prescribe according to the average response to a certain medication. So if the average person responds to this and that, he'll try it on you. And if it doesn't work, you'll have to go back for a change. So the fact is, and I keep saying that we are all that 0.3%, 0.03%, makes us all so genetically unique that we cannot expect to have one therapy for everything. Now, when we talk about eyes, and the reason I looked at this was because of anti-VEGF therapy and the fact that we know that there are different products out there with different responses. And we know that people with a certain gene had a significantly higher risk of requiring extra of one of the injections that is on the market in South Africa today. So it's more than a third of people require extra of this specific medication if we can identify that gene in your life. So it would make sense then that if this specific gene is identified, that we try you on one of the other two products instead. In other words, the response to treatment of macular degeneration, that's wet macular degeneration, with ranibizumab differs according to your genotype. Anti-VEGF therapy also found, and this was a study done by Abedi et al., that they found a single gene that caused a poor or minimal, no response for certain of the anti-VEGF injections. And a literature-based meta-analysis was performed in a different study, and they found that there's certain other genes that could be considered as predictive of whether you will respond or not. So lots of studies have been done, and they're all saying the same thing. We need to know your genetic profile to get an accurate treatment for you from the outset. Otherwise, we have to try, and if it doesn't work, we switch you to one of the other products. Now, there is a new anti-VEGF product on the market. It was launched last year. It is being reconsidered at the moment because it is causing problems with certain people. And at the moment, the doctors are unable to predict who may be adversely affected by this product. But I think it stands to reason, and based on what we've just said now, that if we can identify the genetic profile of the people who are developing this problem, we'll be able to use this new product, which is very good when it works well, but prevent the major catastrophes of when things go wrong. So, in other words, genes and our DNA are going to predict everything in our lives. I also want to include a word or two on what we call tachyphalaxis. This is, once again, just a very big medical term which describes a decrease in the response to a drug after you've been given it. So in the beginning, you respond fine, but then it gradually tapers off, or it can happen quite suddenly, that one dose works and the next dose just simply doesn't. When this happens, we normally advise that you stop that medication. You can stop it for a while and then go back onto it, and hopefully your resistance to the product will be overcome. But probably even better is to switch to a similar drug with different properties. This, in fact, usually involves switching patients, even if they've been on an anti-VEGF, for example, for years and years and years, and it's worked well. If it stops working, you need to switch to one of the others. And if that one doesn't work, you switch to the third one. Luckily, as I've said, we have the options, and between the three options, there will be one that will work. And until we have the full genetic profile to determine which of these will work for which of you, that is the route that we still have to go. In other words, we actually do need genetic testing before prescribing anything. Some people have raised the question of economics. Now, isn't this going to be expensive to have a genetic profile done before you can even have your prescription? Well, remember that the genetic profile in your life doesn't change, so you just do it once. And data has suggested that dosing based on pharmacogenetic outcomes can eliminate massive costs associated with morbidity, ineffectiveness, reactions, and hospitalizations. And in just one study, there were quite a few, but I just grabbed one. In a 3,600 subject study, they found that hospitalization rates for heart patients were reduced by a third if genetic info was available to doctors before they prescribe blood thinners, for example, warfarin. So if they have that information, they don't have to give the underdose, overdose, trial and error. They know what they are doing, and they can prescribe from scratch.
And with extreme accuracy.
Today, there are more than 100,000 genetic tests available to us, and more than 10 tests are still being introduced every single day. Your genetic profile will have a look at a disease or condition, and it will be able to say, will you have a risk taking this a product? Will you have an additional benefit from taking it? Will you have a high risk or no risk of an adverse reaction? Will it be effective or ineffective in your life, etc.? So in other words, you can already get this kind of profile.
I know that this kind of profiling is already available, as I said, and I know quite a number of people who have had it done even right here in Johannesburg.
And based on this, a lot of medication can be prescribed with knowledge and forethought rather than hoping for the best. I'm just going to touch once again on the treatment of macular degeneration because that is so very, very important. We know that early detection intervention is very important. We know that we have intravitreal injections for wet AMD, and in future, injections are coming for dry AMD as well. And if we have the genetic profile of the person, we will know with these exactly which of the products to choose for each of those conditions. But never, ever forget that lifestyle is incredibly important. Lifestyle affects everything, every day, every aspect of every bit of your life. And just a reminder once again that there are 3 types of anti-VEGF injections available today. And if one does not work for you,
your doctor has a second and a third choice available. One of them should work for you.
And I know that occasionally people say, but the one is cheaper than the others and blah, blah, blah. But I want to point out that the less expensive product, if it works for you, fantastic, carry on with it. But don't be deterred if you have to switch to one of the more expensive options, because they can be given 2, 3, or even 4 months apart, which means that the end cost over a year is almost identical. And Claudette and I did that study last year, and we were surprised that when you take all the costs into consideration, there's very little to choose between the costs of the 3 products, in fact, from a cost point of view. The future then of pharmacogenetic testing should help not only for us to prescribe something that helps with you, but it should help to avoid the adverse reactions that we still get today. And we find that very often people take a product and they have a reaction to it. And that can be life-threatening, it can be uncomfortable. Even if it's just a rash on the skin, it is not what you want to live with. It really is an undesirable effect. And we can also, as we've said, choose products that are effective and avoid the ineffectiveness of any medication, as long as you don't decide that you're going to share with your next door neighbor. This should also support physicians to work out the most appropriate treatment with the most suitable drug for each and every complaint, for each and every person as they are there individually. This kind of practice will present an element which will gradually bring medicine from a reactive to a preventive discipline. At the moment, everything that we do as a result of something that has gone wrong. We do it as a result of a symptom that you have developed. We do it as a result of your lifestyle effects, etc. With your genetic profile, we'll be able to predict what you need to do to prevent all of these things going wrong in your life. Besides improving how existing drugs are used and work, genomic research will also help scientists to develop better and better, more effective, more efficient, more specific drugs. And those new drugs should be highly effective and certainly at an individual basis should not cause serious side effects any longer. So we hope that in the future, side effects will be history. I'm going to say a word about a very exciting development that is still going on regarding the future of the treatment of macular degeneration. Once again, I'm talking about wet macular degeneration. And this is what we call subretinal gene therapy. This therapy increases the action of the anti-VEGF injection that you are given. A subretinal injection, a tiny injection of this product, currently labeled AVA101, is given. And in the following 6 to 8 weeks of 2 separate treatments, after those 8 weeks are passed, one anti-VEGF medication is given. So you have 2 AVA101s, 6 to 8 weeks apart, and then one anti-VEGF medication. And that's it. Hopefully, you don't ever need anti-VEGF again. But you need to monitor the eyes. Your ophthalmologist and optometrist can keep an eye on the neovascularization for you. And if there's any sign of a problem developing again, you go and do this again. But in the trials, it's looking really, really good. They packaged a tiny DNA strand inside an adeno or deno, depending what side of the Pacific Ocean you're on, associated virus. It's a little harmless virus. And 100 microliters of AVA101 is injected under the retina. That's all. And they found that with just the AVA100 and your anti-VEGF, after a year, patients gained 9 to 12 letters on the eye charts. So that's very encouraging. That is the kind of approach that is waiting for us in the future. In other words, we don't really have to wait that long. The future is not too far distant. New, smarter, more specific drugs designed specifically with you in mind are already regularly becoming available. And in the future, as we've said, you're going to get a script with your DNA stamped on it as well. At the same time, new delivery systems are being delivered with DNA nanoparticles that are able to deliver the product directly to the retina as well. In other words, what I'm saying is 20th century medication is history. We are now well into the 21st century. A reminder that we need everyone with a retinal condition to join us at Retina South Africa so that we can strengthen the research on our side. Thank you. Over to you, Bea.
Gosh, Kay, that was wonderful. I remember the last time you did this talk that I was really intrigued. And as you said, I went off and had my test done. So one of the questions that we have been asked so far.
Claudette is there. Claudette's handling questions.
Oh, okay. But Sally wants to know, where do we get genetic testing? Claudette, are you there?
So I think we need to differentiate about the types of genetic testing. Now, the testing that you've had, Bea, is what they call a DNA profile, yes, about risks and would you react to a certain type of medication or not. Those you can go to the corner store, the drugstore, and you can send your DNA away. You probably spat in a tube and you put it in an envelope and it all went off somewhere. Those common DNA profiles, you cannot get a DNA test that is related to a serious disease by post. That's the difference. I think that's what we need to realize, is that if you're having a genetic test for a specific genetic disease, that needs to be done under very specific conditions, and it's a worldwide norm. You would go to see a genetic counselor. They would tell you what the disease is, what the risks are, who's likely to be affected, what are your prognosis with the particular type of genetic result. And you would have to then decide if you want this genetic test. If you do get a genetic test done, it's normally done in a basket of tests. For example, for retinal conditions, there are specific, what we call panels, where you would be tested for a specific type of gene mutation to test for your type of genetic disease. And then that result would have to be delivered by a genetic counselor. For example, I know in the early days of genetic testing, you could send away, especially in America, you could send your saliva away and they would write back to you and say, well, actually, you're at high risk for heart disease and also for cancer and for this and for that. So now they've said that that kind of information, a patient sees this, oh my God, I'm going to get heart disease, I'm going to get cancer, I might as well be dead now. So you need a genetic counselor to explain the risks to you. So it's different when you're testing for a disease-causing gene or just how likely you are to respond to a certain type of medication. So those are the differences, and that's what we need to know. So for AMD, you already know if you've got AMD. You can have a genetic test, and you can have it overseas to see which of these mutations you've got. For example, Karen mentioned the complement H factor. We feel that in the not too distant future, this genetic testing to see which of these 30 or so genes that have already been connected to AMD is in your profile. Because it's not only to test if you would respond to this or that anti-VEGF treatment, it also means your children could be tested. And if they have the same gene mutation as you, they can start early in their life with observing, for example, good diet, a good exercise regime, no smoking, sunlight protection, to reduce the impact of the disease in their family and in their case. So yes, it's coming. It's not here yet, but the disease package that Bee's talking about, that is freely available. But testing for disease-specific genes is another ballgame.
Yes, absolutely. And I think even with the other one, you would need to go to somebody who can explain it to you. You don't just receive it and go on with it. They do explain it to you. So absolutely.
Bee, can I ask you, how have you found having the info that you've received just from that basic test? How have you found that has impacted you?
So it was very interesting, but I had it done just before lockdown. So I actually haven't really had a chance to explore too much with anybody, but I think there was some quite interesting things that do come out. And I would certainly be interested in pursuing more about it. Okay, that was really, really interesting. If there are no further questions, then I think that what we will do later in the, I can't remember when you're doing the talk on diabetes, but I think that it's certainly significant to look at these things and to understand what the impact is for you in terms of why it affects you differently. But if there are no further questions, then the talk for next week is on mobility in the township areas. And that will be by Florence Mampura from Guide Dogs. So that invitation will go out over the weekend sometime. Thank you very much and see you all next week.
Thank you, everybody. And thank you, Belinda, and thank you, Claudette.
Well done,
Claudette, for stepping in there. Thank you.
Thanks, Belinda. Thank you, Hazel.
Thank you very much. Thanks, Hazel. God bless everybody. Bye. Stay safe.